Pregnancy and childbirth should be a dignified, safe, and joyful experience for all. But for too many mothers, complications related to pregnancy, childbirth, and postpartum can lead to devastating health outcomes, including hundreds of deaths each year. This maternal health crisis is particularly devastating for Black women, who are more than 3 times more likely to die from pregnancy related complications as white women, regardless of their income level and education. Now, in states like Louisiana, this number is even higher. Black women in that state are 5 times more likely to die in childbirth than white women. During Maternal Health Week, we are raising awareness about Black women and birthing, and we are seeking solutions. We want to make sure that giving birth is safe and joyous. So if you didn't know it, this is Black Maternal Health Week, and we are hoping that by bringing awareness to these issues during this week, and not just this week, throughout the year, we can save the lives of Black women, like my next guest. Super excited to have her here. She's here for our lead-off discussion. She is 31 years old. She's a TV producer, and she's the mother of 4-year-old Noah Ray, and her name is Stevie Carter. Good morning, Stevie.
Good morning. You know, your mouth to God's ears. My baby's only 4 months old, but soon enough, feels like she's already about to go to college.
Oh my goodness. She's so beautiful. And thank you so much for taking some time out. I know as a mother of 3 that these early months, getting sleep yourself can be incredibly challenging, and then getting your baby to sleep too. So if Noah wakes up, no problem. We love babies around here. But just want to say again, congratulations to you and your husband on your birth. And just ask you, what has it been like? What has motherhood these 4 months been like for you?
It has been beautiful. Definitely challenging, of course. A lot of sleepless nights, but definitely a beautiful experience. It's unlike anything I could have ever imagined, but I'm just happy to have such a strong, loving tribe, surrounding me during this time.
Yeah, I'm glad you mentioned that. And I saw some of that tribe on your Instagram page. You have some beautiful photos of your pregnancy journey, your shower, and just the whole experience you had with childbirth. And I asked you in pre-production of the show about your knowledge, because I always wonder how many women like yourself, young women like yourself who are having their first child, how many of them know these really horrible maternal health rate statistics as as they relate to Black women? So did you have this information? And if so, how did you get the information?
Yes, so I did have this information prior. It does come up here and there now on Instagram. It started to become a little bit more viral and trending around last year, the year before, at least in my circles. And it really caught my attention. But I actually did a fellowship on women's health when I studied at Spelman College. And that opened my eyes to just the discrepancies there that happen with women in the healthcare system, for Black women in particular. So I always kind of had my eye on it. I also was, personally impacted with my mother, who passed from breast cancer. And I saw some of those discrepancies there as well. And I just realized we weren't getting many answers for Black women's healthcare. So when I realized I was going to be having a baby, I fine-tuned in. I wanted to know everything I could. It's like I got a PhD in pregnancy because I was nervous, and I wanted to make sure I had everything at my disposal in case I had questions.
That's great. And I'm glad to hear that you just immersed yourself in the whole literature and learned as much as you could about the birthing process. But it kind of concerns me that you said for your circles, this information became, really more prevalent and even viral just a year or two ago. So do you think there are other women in your age group, let's say 21 to 35, that don't have access to this information, or maybe are just coming into awareness of it?
Absolutely. I think that in particular, I'm privileged to even have the time to do the research, to immerse myself in that. There are so many young Black women who simply don't have the time. They're working multiple jobs or just have a steadfast career, and they don't have the opportunity, the time, or the resources to immerse themselves and get this PhD in pregnancy like I did. Right. So I think that a lot of my peers didn't know about this. And for a lot of them, I'm the one that's championing that information because I care about their wellness. more than anything.
No, that's great. I'm glad to hear that you're taking what you learned and now sharing it with others. So tell us, Stevie, once you got all this information, you got your PhD in pregnancy, what did you do to prepare yourself to have a safe delivery?
So it actually, praise God, because my cousin worked for a program in California. It's a state program that gives doulas, that partners us with doulas free of charge for prenatal care, our birthing experience, and our postnatal experience. And that changed everything for me. I was able to have somebody who would advocate for me, who could give me information and resources, answer all my questions. One thing I didn't know was that when you go to those checkups for your pregnancy, those appointments are like 15 minutes and they have you out the door. And I'm like, oh my gosh, I still have so many questions. It felt so rushed. And I just felt like that program in itself really changed the trajectory of my pregnancy for me.
At what point in your pregnancy did you get connected with a doula? Like how many months were you?
I was about 4 months in. And that was a pivotal time for me too, because statistics show that a lot of Black women deal with insurance issues as well. And that happened to me. Me and my husband both work for ourselves, and we dealt with a healthcare lapse in the middle of my pregnancy. And because California was trying to figure out who would take on the brunt of my healthcare, I actually had a lapse in healthcare for 3 months.
Wow. So were you
in my
able
second
to get
and third
care during that 3-month period?
I had a Black doctor. I won't say which hospital because I don't want to, but I had a Black doctor. She took such good care of me. She actually snuck me in for some of my prenatal care free of charge. And I know that it could have been detrimental to her, but she took care of me. And I'll get emotional thinking about it because I was so stressed. You can imagine the stress that you have not having healthcare coverage in the middle of your pregnancy. It was horrible. And everybody in the California healthcare system kept apologizing, but nothing was getting done. Nothing was being expedited for me. Mm-hmm. So that in itself is just an example of how you have to, I felt like I had a part-time job just trying to get my coverage back.
Wow. And fortunately, you did get it back before the actual delivery, right?
Absolutely.
And kudos to that Black woman doctor that, probably broke some of the rules at the hospital, but wanted to make sure that you had good care because she knew you were going to eventually get the health insurance. And I'm sure she didn't want to risk anything happening to you along the way. But I do want to ask you about the delivery. I know, again, looking at your Instagram page, you shared some pretty intimate photos of you pre-delivery, and some of those photos, you look like you were in distress. So did you have some complications with the delivery?
So I did have some unforeseen circumstances in my delivery. The good news was I felt prepared going in to know what my options were. My doula prepared me and my doctors prepared me to know what my options were and my choices. So I had a preference plan ahead of time. But while I was giving birth, my doctor was not available. She wasn't on rotation. So I had another doctor who immediately came in and tried to rush my birthing experience. I was making good, steady progress. She came in, I felt like she did not read my chart and told me that I needed to take Pitocin to induce my labor and that I could possibly be having a C-section. Nobody else prior to her said anything about a C-section or inducing. It caught me completely off guard. And the language that I wish women had that I learned prior was, okay, is this decision going to cause immediate harm or danger to me or my baby? Or do I have a moment to think about it and discuss it with my partner? And when I said that, she slowed down and said, oh, you can talk about it. I said, okay, let's revisit this in an hour. If I haven't made any headway, we'll go from there. Mm-hmm. And in 1 hour, I went from 5 centimeters to 8.5. I was totally fine. If she had just given me 1 more hour, it would have been okay. So I'm starting to push. I'm about 3 pushes in. I'm getting frustrated, as you saw in that photo there. I'm hunched over. Then she comes up to me and tells me that she has a personal emergency and she has to go.
No.
So I am left there, the doctor, and she told me that she's going to bring in some other women to take care of it. I don't have words. So I just honed in. Me, my husband, and my doula. Thank God we're all there. We huddled around. and we got that baby out.
Who did she bring in? Who was her replacement?
Brought in 3 other doctors who came in, and to their credit, they were fantastic. They cheered me on. They were awesome. But that type of shift while I'm trying to push my baby out into the world, I don't have words. I was so frustrated. So as I was pushing, they actually had to use a vacuum to help suction my baby out as I was pushing. Thank God I was already aware of what that process would look like, doing some research, but nonetheless, of course, it was scary. But yep, baby girl came out. She was here a couple pushes later, and yeah, I'm just so thankful.
Let me go back. A couple of things you said, just, oh my God. So the woman says, I got a text, I got a call, I got a personal emergency, I'm out, some other people are coming in, handle it, you'll be fine, have that baby. And of course, your stress level went past the 10, I can imagine. You already don't have your doctor. And I had that same experience with my second child, where the doctor that was the doctor I had the relationship with couldn't make it to the hospital. I don't know, LA traffic or something. And I had a different doctor. In fact, it was a guy. My doctor was a Black woman. This was a guy, and I swear he looked like he had just graduated from high school.
Oh my God.
And I was like, okay, I need to see like a medical degree, a license, something. Like, dude, I respect young people. I was a young woman. But so
There's something about
in that moment, a high school graduate for your doctor is not who you want to see. But okay, so I know that experience, and I'm going to ask our experts, how often does this happen, that these changes happen in the middle of your birthing process, because it's very traumatic to the mom. But I also want to ask you about the vacuum process. What caused that? Why did they have to use a vacuum?
They told me that her heart rate it's the viability of her heart rate. So it wasn't that it was really slowing down, but her movements, her viability, they said was low, and that they didn't want to risk her being in there during the pushing process a lot longer. Mm-hmm. So I was having a really hard time pushing in the, big thrust, and the baby comes out. That was not the case. So, as I was pushing, I was getting frustrated, and they said that they could do that, pushing her out, and they were getting her out. I had to have a slight episiotomy as well. But they were very communicative during the process, which I could appreciate. And every time things like that happened, my doula was there to talk me through it. Hey, you have a moment here. What do you want to do? I think there's so many times in that process that you feel like everything is a split-second decision. And that's sometimes how you feel pressured, for those dangerous kind of moments, if you will.
Now, did your doctor ever come back? Like, did she visit you after you had the successful delivery?
No, she actually had I think she had a cesarean schedule, and I don't know what happened there, but I never actually saw her after the birth.
Well, congratulations on getting through that process, managing the stress. Thank God for the doula and your husband who were there to help you through. What about after you delivered? Did you have any? We hear so much about postpartum depression, and we know that many women experience issues, several months even after they've delivered. Did you have any, or are you having any postpartum or just, ongoing medical conditions related to the pregnancy?
So far, so good. Everything has been really good as far as my physical health. My mental health has been good. I've already subscribed to therapy. I love therapy. So, we have a family therapist that we work with, and she's been awesome too. And I think that made a huge difference to know what the signs are, to be able to understand some of the differences between like your normal baby blues, because those first 2 weeks, I can barely tell you about them. I felt like I was in the trenches, you're not sleeping, I was trying to breastfeed, which is a whole other journey, and I felt like those first 2 weeks were really, really challenging, but understanding the signs of postpartum depression made a huge difference. And then also knowing family history. I found out a month ago that my mother actually battled with some postpartum depression with my younger brother. So just being aware that could come down the pipeline, even if I have more kids in the future, that's huge. Wow. But I think that we don't talk about that enough too sometimes in our Black families about how that kind of stuff happens.
Yeah, no, I'm glad you mentioned that. I don't remember people even telling me that there was such a thing and what the signs were. And I love that you said you're already in counseling and you were able to talk to your counselor about, what signs you should be on the lookout for because your body goes through so much and there's so many emotional changes that you go through after you have a baby. It's really quite incredible, the whole process. So, what about now? You've had this baby, she's healthy, you've learned so much about this process. What do you think this country should do, health system should do to make this process easier and so that we really address what happens to Black women in particular with childbirth?
Yes, I think that there are three things that could help. I think the first is just to see our humanity and our personhood as Black women, validate my experiences and what I'm telling you. I think that's huge. The second thing I would definitely say is to create more resources for the pregnancy experience, the birthing experience, and definitely postpartum, whether it be through our healthcare industries or just our local opportunities for Black women would be super helpful. And then I would also say more scientific and medical research regarding Black women. It was hard for me to find things specifically tailored to our Black experience. Just one little thing that happened to me, my postpartum experience, I got out of the shower one day and realized that my entire stomach was 5 times darker than the rest of my body. I did not know that that was a postpartum symptom. And I talked to a doctor about it and they didn't know what I was talking about. And that freaked me out. I'm like, oh my gosh, is something wrong? Am I bleeding internally? And it wasn't until I went onto my Instagram and talked to my followers and friends that I found that's totally normal. So it's little things like that that can make all the difference too. But if we had more research for Black women in the medical field, I think it would change the game for us.
Well, who is your what doctor did you talk to that didn't have that information for you?
This was not my
Like your
doctor.
family practitioner? That's what is it your family doctor or?
This is somebody, she wasn't my family doctor. My actual doctor, she was gone. So I had to do a checkup for my postpartum and they assigned me someone. I figured it would be fine.
And to your knowledge, was this person an intern?
There, but one of those questions, she was confused.
Wow.
I'm sorry?
I know. I was just curious. Was she an intern?
Oh, no, not an intern. No, she seemed to be an attending.
Oh, okay. And she had no clue about the discoloration of your stomach.
No, she thought that my linea nigra, the line that is going from like my belly button down. I said, no, not that. My entire stomach. And I showed her, and she said, "Oh, I think it's just hormonal." I'm like, "You think? Is it? What's going on?" So it was things like that that just had my mind blown.
Yeah. Well, one thing we hear, Stevie, a lot, we've done a lot of shows on Black health and some of the structural racism that we see in the healthcare field. And one of the common myths is that Black people and Black women in particular have this higher threshold for pain. Did you have any experience with any of your doctors or the nurses or the healthcare professionals where you felt like they were treating you differently as a Black woman and that maybe you could endure pain levels that other people can't?
I have to be honest. When I was pushing that birth experience, I tapped out. I had my face on my husband and my doula, and I'm like, because at that point, when my doctor left, I was just out of it. Everybody in the room was cheering me on, which was beautiful. Push, Stevie, you got it. You're strong, mama, you got it, which was really nice and encouraging. But in that particular experience, I didn't experience that. But I think that those women were aware of some of those experiences from Black women, because one of the doctors came over to me and said, we're here to advocate for you. I want you to know that you're feeling heard. And I said, thank you, towards the end. So I think that they might have.
Somebody got the memo, huh? That Black women do not feel heard. Okay, well, kudos for that doctor for at least acknowledging that. That's a good first step.
Yes.
Well, I am so happy that things turned out well for you. Your daughter's beautiful. Your family, I'm sure, is super excited about the new baby. Got to ask you, is number 2 in the works or plans for number 2 or possibly 3?
sometime down the line, for sure. We want to give little Noah a sibling.
Well, you sound like, and from everything you've said, you are going to be and already are an incredible mom. And thank you so much for sharing your story. It will help so many people. As you said, not everybody has the privilege to take the time that you had to learn all the information that you had to learn on your own about this process. And we want to help make this process easier so people don't have to feel like they have to get a PhD in pregnancy just to have a safe delivery. But good luck to you and Noah and your husband. Continue to enjoy these early days. I tell you, as a mom of three, they go really quickly. So have fun with it. Thanks so
Thank
much.
you so much, and thank you for doing this, Areva.
All right, my pleasure. My next guest is Dr. Rachel Hardiman. She is a tenured professor at the University of Minnesota School of Public Health. She's a reproductive health equity researcher, and she's dedicated her career to studying these very issues that we're talking about this morning. Good morning and welcome, Dr. Hardiman.
Good morning. I'm so happy to be here.
I have so many questions for you. Stevie raised so many great points about the whole birthing process. Why don't I bring Dr. D on at the same time? Because she's a lecturer at Yale School of Nursing. She's a veteran nurse. She has over 20 years in maternal health. She's been in some of those birthing rooms. So I really want to find out from you, Dr. D, about some of the things that Stevie told us to find out if they're common. Let's start with this changing of doctors, this doctor with a personal emergency that had to check out and sends in 3 new people. So here's a mom already not without her regular doctor that she has a relationship with. She has doctor number 2 who's talking about C-section and trying to rush her. And then here are 3 new people. Is that common in the birthing process that you'll have that kind of transition?
Yeah, unfortunately, it does happen more frequently than we hear about, or that we're, pregnant women and delivering women are aware of. And many times this is just as a result, if you're in a teaching hospital, sometimes, to get residents exposure, or if it's, just a changing of the tour, this can happen more frequently than we admit. So it is important for birthing people to set those expectations with their providers early. Is there potentially an opportunity where I may end up with a different provider than yourself? And certainly emergencies happen, but is this a common thing that could happen? These are some of the questions that we should be asking during our prenatal visits, and when you're screening your providers to make sure that there's that continuity of care. It's one thing if you know up front that this might happen, and then another, as our guest just said, it just happened out of nowhere.
And Dr. Dunkley, what about this C-section conversation? So I had an opportunity to interview a Harvard medical doctor who also does Black Maternal Health, and he talked about the C-section piece and how Black women are often pushed into C-sections when they don't need to have C-sections. And there are these algorithms, he said, that are taught in medical school about when you should give a C-section and not, and that the algorithms are biased and that more Black women have unnecessary C-sections. So Stevie said the new doctor walks in and immediately starts rushing her like, okay, maybe we got to, you've got to have a C-section. Is that common? Are doctors walking into birthing Black mothers' rooms saying, hurry up, got to get this baby out, got 10 other people waiting, need this bed, which is kind of what it felt like?
Yeah, there are some non-ethical things that do happen. You do have good providers who, treat their patients with care and make sure that, they're patient, with their patients. But you do have some who, depending on provider preference, right, the indications for the C-section may be fudged, or, they got to get to whatever they have to get to. And that unfortunately does happen. So when you have that situation and you feel helpless and not empowered to question it, or, as our guest asked for additional time to think about it and consult her family, folks feel pressured into making that decision because you're thinking this is a medical expert. Of course, the indication has to be there, otherwise they wouldn't suggest it. But this is part of the problem that we have, is that there are variations in provider just personal ethics and preferences. And these are the results that sometimes happen. most of the time due to some kind of bias, implicit or otherwise.
Yeah, Dr. Hardiman, let's talk about that. I mean, this whole week, Black Maternal Health Week, is about raising awareness. And some of the awareness is around these ugly statistics about Black women dying in childbirth. What is the U.S. getting wrong? Because again, the richest country in the world, you would think we would get this right. But here we are in 2022, and we still have these statistics.
That's right. We are the richest country in the nation, or in the world, right? And we are seeing these horrible statistics for Black moms, Black birthing people. And a lot of what's at the root of it is racism. And by that, I'm talking about, this big picture that I think is hard for people to sort of wrap their heads around, because we're talking about the ways that housing, education, employment, all of these big things in our society are impacting Black moms, Black families, and Black birthing people and putting them at a disadvantage. And that shows up in a variety of ways. And what we see in the statistics, in addition to the fact that Black women are 4 times more likely to experience maternal mortality, we see that Black women, regardless of their socioeconomic status, so even folks who are well-educated and high SES, high socioeconomic status, are at greater risk for these outcomes in comparison to white women who have a high school diploma. And that tells us that there's something sort of fundamentally wrong with the way that the ways that Black women, Black birthing people are being exposed to our society. And so what our research has shown is that structural racism is a fundamental cause of the inequities we're seeing in Black maternal health.
And Stevie said something else. I took a lot of notes. I was just wanted to make sure I remembered everything she said. One of the things she said was, even though she immersed herself in the literature and she feels like she got a PhD in pregnancy, she said she didn't find a lot of research that was specific to Black women. So I know you are a researcher, Dr. Hardiman. Was she looking in the wrong places, or does this research is it just not out there?
Stevie is absolutely right in sharing that there was not a lot of research focused on Black women. And one of the things that I take very seriously in my role is using data to make injustices like these visible and using them as tools to help Black birthing people like Stevie learn and get that PhD in pregnancy. I would also argue that no one should have to do that, right, to be able to birth safely. But there is, I think over the past couple of years, we've begun to sound the alarm on Black maternal health and Black maternal outcomes. I'm grateful for Black Maternal Health Week and the Black Mamas Matter Alliance, who 5 years ago launched Black Maternal Health Week, because it has begun to raise awareness. But we still have a long ways to go to really use the data that we have to help Black birthing people and their families prepare for pregnancy. So I have friends all the time who tell me, are pregnant and are Black women who tell me, I've seen that risk, that the statistic, the 4 times more likely to die, and they're fearful and they don't know what to do or how to think about that as they go through their pregnancy. And so we need more resources in addition to working to fix that and really change the system that is allowing these inequities to happen. We really have to be also equipping families with the tools to be able to be safe and get what they need out of their pregnancy and make sure it is a dignified experience.
So, Dr. D, in addition to the C-section conversation, the conversation also, the issue of Pitocin, which is that medication that speeds up labor, that also came up in Stevie's delivery. Is that common? Do all women or all people who give birth, do they get Pitocin, or is that something, again, that's used by hospitals to, make this process faster so they can get the next patient in?
I would love to say that every time that Pitocin is used, it's for medically reason or has a medical indication behind it. But again, when you have best practices that folks have to be accountable, right? So you have these safety bundles and the best practices and the guidelines that come down from these regulatory bodies like ACOG, ACNM, and so forth. The research is there, right? The recommendations are there, but there's always room for provider discretion, if that's the word. And a lot of times, depending on that person's bias and, their level of patience, they may decide to do something to speed up this process, as you said, and Pitocin is one of the choices that that is most frequently used. It is not used for everyone. We do naturally produce oxytocin, which Pitocin is just the man-made form of oxytocin that naturally occurs in our bodies. It's that hormone is the hormone that induces labor, right? So we give you a little more to kick it up a notch. But unfortunately, it is not used equitably. And it can have effects, it can have devastating effects if it's not medically indicated. And so, I wish I had a good answer for you in that everybody, it's equitable and fair in its use, but it's not. It's actually overly used, in my opinion.
Yeah, and Dr. Hardiman, Stevie, obviously, she's a Spelman graduate, super smart woman.
Yeah.
She said she had learned this language because she had this doula. So she was able to say to this doctor, is this medically necessary that I make this decision in this moment, or can I have more time? So that's a pretty sophisticated thing to say. First of all, if you're not in labor, but if you're in labor, to be able to articulate that, is probably not common. So when you have people that don't have that kind of language or don't have that free doula, which she had the privilege of having, what happens to moms? Again, I think Dr. D put it best. If a medical professional, someone in scrubs comes in and says, hey, you need Pitocin. They're like, okay.
Right. So we are.
They're like, okay.
Exactly. We're trained and we're socialized to assume that physicians and nurses as healthcare providers know what's best. And so I think that's part of it, is that, there's many of us who just don't even think about questioning it. And then the other part is for Black women who do question it, they also often get labeled. So some of our work has shown that then that's the person that gets labeled as aggressive or quote unquote non-compliant as they're interacting with, the providers and the healthcare system. And so and that leads to a whole nother cascade of problems across, the care process. And we have to be thinking about how to better train our clinicians and our providers, right, to understand the role that racism plays in showing up in the healthcare system and in the lives of the people they're caring for, and really making sure that they're thinking very clearly about how they're interacting with birthing people and their families, like Stevie.
And Dr. D, I read an article that said that we being the U.S. medical system, know how to treat the leading causes of the deaths that we see in Black women giving birth. And they identified those two causes as hypertension and hemorrhaging. Do you agree, first of all, that those are the major causes that result in deaths of people giving birth?
Yes, absolutely. And just as a blanket statement, most pregnancy-related deaths are preventable, right? And so that research is there, it's been proven, and you listed a few of the top five, if you will, causes. Majority of the causes of death are cardiovascular related, infections, hemorrhaging, right? And then the hypertensive disorders like preeclampsia, eclampsia. We know how to treat those things, right? Early detection, proper patient education, access to care, right? And as Stevie, I feel like she touched on almost every aspect of what's wrong with our medical system, right? She was uninsured for a brief period of time. So imagine how many women or birthing people experience that, either are underinsured or uninsured, right? So that prevents them from having that access to care, right? The knowledge, right? The knowledge deficit on the part of the birthing person. But again, it should not be up to just the birthing person to ensure that they have a safe delivery, right? That's where we come in as providers to help educate you, right? Based on our knowledge of maybe what you might be at risk for, and other factors. So it should be the onus of the healthcare provider to help guide that person to the best outcomes. And we know that's not happening. And the research also is showing that these things, these complications, well, maybe not every complication, but the deaths are preventable.
So, Dr. Hardiman, Dr. D says the research is there. It's clear that the deaths are preventable. We know the top 3, the top 5 reasons why women are dying. Why aren't we acting on it?
I think there's a lot of reasons we're not acting on it. And this is, I think it's an important policy and political discussion just as much as it's a healthcare systems level discussion. And so when I think about where we should be headed next, and particularly as I reflect on where we've been, this week as, during Black Maternal Health Week, I think we're still working towards that goal of a world where Black moms have, the rights and the respect and the resources to thrive, whether it's before pregnancy, during pregnancy, and in those years postpartum. And, I think part of what has sort of challenged us along the way is that we, for a long time, were framing this issue as one of simply race and not racism, right? So as a result, we were thinking about this as a biological failing of Black people. And, by framing it as race, it suggests that there's some sort of genetic predisposition that is causing Black birthing people to have these bad outcomes. When in reality, if we frame this and understand that, racism and all of the ways it impacts people's lives, the ways they access the healthcare system, the care they don't get or do receive that might be inequitable, it allows us to really understand that this stress pathway is being activated constantly in the lives of Black moms, Black women, and that's harmful for outcomes. And so it means that we have to be focusing on really big, I think, challenging issues to fix this problem. Some of them are issues within our healthcare system. So Stevie talked about the fact that her prenatal appointments were only 15 minutes long. That's not long enough to build a relationship, a trusting relationship with a provider and someone that you're expecting to care for you during 9 months and also help you bring a new life into the world. We also have to be thinking about bigger issues like housing and employment and how that impacts the lives of birthing people. One of the things I, think a lot about is how COVID-19, we haven't scratched the surface of how the COVID-19 pandemic will impact Black maternal mortality. And I don't mean just the deaths of Black moms who had contracted COVID, but really the reality of the 2 years that we lived in where there was high stress, particularly for Black communities that were disproportionately being ravaged by COVID-19 and what that's meant for Black families and Black pregnant people. And so, I think we are in a place right now where we know where we need to head. It's going to require a lot of political engagement and policy engagement, both at the federal level, but also within our own states and cities and, holding our healthcare systems accountable to ensuring equitable outcomes.
Yeah, I'm glad you mentioned the distinction between race and racism because Dr. D, the maternal health doctor that I interviewed from Harvard, talked about medical school and what he learned in medical school. And now as a professor at Harvard Medical School, what he is trying to do differently. And he said in medical school, all the models, all the examples, you're pretty much dealing with white women. And even that skin issue that Stevie talked about, he said that, he didn't say that specifically, but he talked about how issues related to skin color wouldn't necessarily even be visible to or knowable to doctors in medical school because they're not taught on bodies that have, pigmentation like Stevie's body. So have you seen any change over the last, say, 5 years or so in the way students, nursing students in particular, the students that you deal with, are being taught? Is the subject of race, are they bringing in people of different color, or are we just still working with white bodies?
I do think that these are really great points that you're bringing up. I do think that there's been a bit of a shift, at least if not in action, in conversation, right? We're beginning to realize that there does need to be changes made in the way that medical education and nursing education occur in terms of bringing in more diversity, equity, and conversations around that and how we care for the diverse populations that we serve. Certainly in nursing education, it is a focus. But depending on the organization that you attend, right, may not be interwoven into the curriculum as much as we would like. Organizations like the NLN, who play a huge role in standards set for nursing education, have already come out with guidelines and a toolkit on how to do this, how to implement conversations around diversity, equity, and inclusion, social determinants of health, health equity, structural racism, and all of those things that affect the outcomes that we now see into the curriculum. But it is a heavy lift. You know, in the course, one of the courses that I teach, it's a joy for me to teach because I get to just specifically just lay it all out there. The whole course is about these issues, right? So my students are getting an amazing exposure, and we have great dialogue about what kind of practitioners they're going to become. However, this is not necessarily the case in every school. Right. So we do have, it's a heavy lift, and we have a ways to go. I do, like I said, I think the conversations are happening, the wheels are churning, but we have a ways to go in the way that medical and nursing education is framed.
Dr. D, what are some of the questions that your students are asking? Those students perhaps that have never been exposed to these conversations. Mm-hmm. What are some of the interesting questions that you're hearing?
Many are not aware of, okay, so we did a lesson on just kind of medically biased, historical bias practices. And one of the things that came up was about with kidney disease, right? The glomerular filtration rate, right, is adjusted for African Americans. For what?
Okay, not a lawyer, not a doctor. Yeah. What is that rate?
So basically, they tend to have a higher threshold for African Americans than other patient populations, and the whole thing is racist and biased in its foundation.
What rate? So again, what process are you talking about with the kidney?
So there's a test that they do. I'm trying not to give you too much medical jargon, but basically it's a way to test to see if you're at risk for kidney disease.
Okay.
And so they already adjust what the normal rate and the at-risk rate is. They make it higher, right, for African-American populations. And none of it is based in biology. It was always about race.
So by making it higher, what does that mean practically?
Right. So then our threshold, we may be underdiagnosed, right? And the symptoms may not.
Our kidney disease because
exactly.
The normal rate is 5. They say look for 8 for blood.
Exactly. Okay. Exactly.
Okay, I got to get this down to 5th grade level.
So. No, absolutely. I didn't want to get too much into the weeds, but you're absolutely on the right track there. But things like that, right? And this is medically accepted.
There's no medical reason why we shouldn't be at level 5.
No
concern for Black people versus waiting until we get to level 8.
Exactly. And so and things like this that are embedded into medical practice, they're going to take a while to change. And so they had so many questions about, why, right? And so, they're curious. And one of the things I do notice, though, is that this next generation is very much socially justice aware, and they're not having it. Good. They want to be allies. They want to make change, sometimes immediately, but we know that it's going to take time. So I'm loving the enthusiasm that I'm seeing from the younger generation.
That's really good to hear. And Dr. Hardiman, we heard, and we didn't get the age of that doctor that Stevie said came to her and said, I want you to know I'm hearing you, I'm listening to you, because that is one of the things that in my interviews with so many everyday people like Stevie who've been through the medical system for whatever reasons, as well as experts are saying that Black women in particular don't feel heard. Doctors are not listening to them. Maybe in that 15-minute, I thought 15 minutes was kind of long because I think I've had 5-minute appointments where literally you weigh, they take your blood pressure, they do something else, the doctor runs in, you having any problems? No, okay, see you in 3 months. So, it could even be shorter than 15 minutes. But do you think that is changing? Maybe this younger generation of folks that Dr. D is training, that they do understand that listening to Black women is so critical to breaking down some of these barriers?
Yeah, I think it is slowly changing. I agree with Dr. D. Like this next generation is just astounding. They're fine-tuned into social justice, racial justice, and they've done some great work and really holding their institutions accountable for changing curriculum. I would also add that, you know, we can't just rely on this new generation, right? So some of the work that my team has been doing is really to think about how do we, you know, those providers that are right now practicing and caring for Black women who are reporting that disrespect and not feeling heard and feeling, you know, that bias in their interactions. How do we change that as well? And so it's, you know, that training piece is just as critical there. And we've seen legislation passed in California as well as in Minnesota that has now mandated that perinatal care providers, so anyone who is caring for pregnant people in each of those states, is now required to go through implicit bias and anti-racism training. And I think, and that's not to suggest that, you know, a training will sort of change all hearts and minds and things will be much better, right? But I think it's an important step towards both, you know, raising awareness, educating people on this racism, not race piece, and then moving forward with tools that will allow for more providers to care for Stevie in the way that that provider did when she, you know, came up to her and said, you know, we're here for you and we, you know, we hear you and we support you.
Yeah, thank you for sharing that California and Minnesota both have passed legislation, because you're right. As hopeful as we are about this next generation, there are people who aren't benefiting from this training that's happening now. And they were trained in medical school 10, 15, 20, 30 years ago, and they are still very much active in hospitals and birthing centers around this country. So those folks have to be reached, you know, because they weren't the beneficiaries of even, you know, the concept that we need to study bodies other than white bodies when we're talking about birthing. So we've got to reach that generation of doctors that are already practicing. Last question for both of you, I'll ask you. One thing that Stevie said, again, I thought was so important was the fact that, one, she's in therapy, her family's in therapy, and she knew what to look for in terms of postpartum depression. We know postpartum depression is also something that isn't talked about a lot, not a lot of resources available, particularly depending on your socioeconomic status. But do you see us moving to a place in the birthing process where there's much more of a multidisciplinary approach that's being utilized, where it's not just the doctor, but it's the social worker, because maybe you're going to need WIC, or maybe you're going to need some benefits after you have the baby, or housing, as you talked about, Dr. Hardiman, and there's a mental health provider because maybe your mom, as Stevie said, her mom suffered from postpartum. So there are people that are in this team from the beginning, not when the crisis arises and now you've got, you know, to get some response to a crisis. But do you see us moving in that direction in maternal health, where we're bringing in those professionals that will allow for a more holistic approach to the birthing process? I'll start with you, Dr. D, and then I'll give Dr. Hardiman a chance to answer.
Sure. I think that some organizations are getting it right. Yeah. Right. Some obstetrical providers have these really integrated systems where they do bring in additional support throughout the pregnancy into the childbirth, and you know, depending on the delivering hospital, that process is supported and continued. What I think is that we don't do a good enough job of engaging some of the community grassroots organizations that are already doing this work. I mean, just incredible nonprofit organizations that are attempting to bridge these gaps, right? But the funding is not there, right? And I think that we certainly need to lobby and really push harder at our legislators to approve additional funding to pour into these organizations that are already doing the work. Like, it's not, they haven't reinvented the wheel, but they're not able to carry out some of the projects and initiatives that they would like to on a grander scale because they're, you know, they're struggling for funding. So I do think we're making progress. We are, and I really do hope that this new Momnibus bill, all parts are approved and additional things like it will come forth as a result.
Great. And Dr. Hardiman, as you think about that, also, what is the most important thing you want everyone to take away from Black Maternal Health Week? Like, what can we as individuals do to have an impact?
Sure. So I want to just underscore what Dr. D just shared, right? That there are models out there. We didn't talk today about midwifery models of care and birth center models of care that have really transformed the way that care is delivered for Black birthing people and their families. And then there's this issue of access, right? And because we have an employer-based health insurance, it makes it really hard for people who want that care to be able to access it. But I do think we have to continue to push those boundaries of thinking about how to work collaboratively so that we're making sure that families have that holistic care. I think from a policy perspective, one of the things we've seen, are starting to see, thanks to efforts from Congresswoman, Lauren Underwood and others, is Medicaid expansion into that first year postpartum, so that people who might be at risk of postpartum depression actually have coverage. So typically, if you're a birthing person on Medicaid, you're cut off from coverage at the 6-week point, postpartum, which seems, really silly, given that we know that postpartum complications can happen up to a year out. And so ensuring that people continue to have access to care is incredibly important. But, in response to your, final question, sort of about what do I want to leave people with around Black Maternal Health Week, I think for me, the crux of Black Maternal Health Week is the ability to say that and to lift up the voices of Black people, Black families, Black moms, right? And because really at the crux of this issue is the fact that Black moms and those who are closest to the pain of Black maternal mortality should be the ones developing the solutions and speaking out on what that should look like in their own communities. And this week, and certainly that should happen beyond this week, but I think this is, week in particular is an opportunity to really highlight that and to shine a light on all of the wisdom, right, and knowledge and the assets in communities. We so often are thinking about how Black women are at risk, but we haven't really stopped to talk about what is it that Black women and Black doulas and Black providers and physicians and nurses bring to the birthing experience that makes it, culturally centered, that makes it, a beautiful and powerful experience. And how do we learn from that? And how do we build that into our healthcare systems?
No, I think that's great. And thank you for bringing up the alternative birthing centers. And I'm glad Stevie mentioned the doulas, but she did say she was the beneficiary of a free program that's offered in Los Angeles County. We know lots of counties don't have those programs. And I've had lots of doulas on the show before who've talked about how difficult it is for some people. And I remember one woman told me that she wishes in the Black community, rather than those elaborate baby showers, that people pool those resources, buy the baby some needed things, but also maybe give that money to the family so that they can hire doulas, because doulas aren't often available for people depending on your socioeconomic level. But as we saw in Stevie's case, they can be so incredibly important to helping moms through that process as they give birth. Thank you so much, Dr. D. Always a pleasure to see you. And thank you, Dr. Hardiman, for joining on this very important conversation. And yes, this should not just be about this week. We should be lifting up the voices and the stories of those Black women every day of the year, because we know how to save the lives of Black mothers. Now we just got to get busy about doing that work. Again, thanks for joining me this morning. I want to thank all of my guests. I want to thank Stevie for sharing her beautiful baby with us. And thank you to our experts for helping us understand what this process is like and what we can do. And one of the things we can all do is write to our Congress people, write to our senators, and make sure that they are making the health and wellness of Black mothers a key priority when they think about legislation that they are advancing or legislation that they are supporting. Just some words to live by before we get out. Maya Angelou, one of my just all-time heroes, said, when you know better, you do better. And we've heard these experts say the research is there. It's clear. We know how to save the lives of Black women and Black birthing people. Now we just need to do it. These deaths are preventable, and we need to stop acting as if they are inevitable and shift this narrative. Focus on those injustices that are preventing us from saving lives and get about the business of making the birth process joyous and safe for all women, particularly Black women. All right, I'm out, y'all. Be safe out there. Don't forget to register for the Special Needs Network upcoming Social Justice and Autism Conference on April 30th. We're going to be welcoming Dr. Michael Eric Dyson, 7 times New York Times bestselling author. We got 9 free workshops, free breakfast, free lunch. lots of resources and those $500 IKEA gift bags, as well as food boxes for those that have been impacted by the pandemic and may have been experiencing some food insecurity. So make sure you check it out at the Special Needs Network website. I'll see you there. I'm out. Remember, we're all in this together.